At the outset, I would like to thank Dr. Parda and Dr. Kotari for having invited me to spend these few minutes with you. I think when I entered the hall in the morning, I found that there were hardly 2 or 3 postgraduates. And as I started to listen to Dr. Krishna Das, I felt how much the others have missed in this first lecture. It was really a fantastic lecture by Dr. Krishna Das, which I really enjoyed every word of it. I'm practicing ophthalmologist. The real pearls that he has mentioned in his lecture. So I would suggest that as postgraduates, you should maintain your time and be very punctual to the lectures because you really learn from experienced people like Dr. Krishna Das. Okay, without much ado, I would like to talk on this particular subject of optical imaging in posterior segment diseases. Now, optical imaging would include actually, the first I chose the word imaging, then I changed it to optical imaging because it would be impossible to cover all imaging modalities that are used in ophthalmology in 45 minutes, which would include ultrasound, UBM, X-ray, radiology, etc., etc. So we'll just restrict our talk today to optical imaging. And these are some of the subjects we are going to cover. Let us start with the most fundamental of everything, which is fundus photography. It is nothing but documenting what you would have otherwise seen by using your indirect ophthalmoscope and slit lamp biomicroscopy. You can use a film or a digital mode of documentation. You can use the newer versions of wide-angle photography and montage. Let us see where really it is useful. Is it a fancy thing that you just click on every patient that walks into your clinic? But are there any specific indications for doing fundus photography? One is, of course, to document a disease. If it's a rare disease or you want to share with your peers or in a conference like this, you would like to document the disease. It may be for a patient education value. In fact, more often than not, that's where it is going to be used. You take a picture of optic disc as, for example, a case of glaucoma, and show him this is how your optic disc cup is. And if you don't treat, this is how you're going to lose your vision. He understands better. Somebody who comes with a malignant melanoma, observed just on routine examination, no visual symptoms at all, it's very difficult for you to convince him that he has got a cancer inside the eye. But you take a fundus photo and show him, he understands. Likewise, you can use it to compare a disease over a period of time with or without treatment. There are diseases which you follow up as observation and diseases which you treat. Either way, you would like to compare and see what is happening to it. There's also one particular area where wide-angle photography is extremely useful. Of course, it's important that you can document a larger area of retina in one picture instead of creating a montage. But in eyes with very small people like those which have undergone a Boston K-Pro or a OOKP or orthodontokeratoprosthesis, the pupil is very small, hardly 3.5 millimeters. And it's very difficult to see the fundus, even with indirect ophthalmoscopy. So if you use wide-angle photography, you can see the fundus much better in such cases. You can use fundus photography as a screening tool for diabetic retinopathy and retinopathy of prematurity, where the first contact person is not an ophthalmologist, but maybe a technician who takes a picture. And these photographs are sent by electronic media to doctors who will screen them at their leisure and advise whether they need to be seen by the ophthalmologist or not. This is just a picture of the wide-angle photography. Please understand that the color rendition is not great, but still it gives you a good overall view almost up to the ora serrata. And a montage which is similar to the wide-angle photography, except you need to add these pictures electronically. Let's talk briefly about autofluorescence. This is still a modality of photography where you do not inject any dye intravenously. Fluorescence is a property intrinsically of certain pigments in the eye, such as lutein, zeaxanthin, lipofuscin, and melanin. And these, by virtue of this property of fluorescence, can be used to detect their presence by using this autofluorescence. Basically, we use 2 wavelengths, the blue wavelength or 488 nanometer wavelength, or the near infrared wavelength of 790 nanometers. And again, 2 modalities are used, the reflectance and fluorescence. Suppose you choose a 488 nanometer blue light and throw it inside the eye and record every light that comes back from it. That is called as a reflectance, because you're not filtering away the reflected light using any barrier filter. While it is called autofluorescence, when you filter away the reflected light, so much so that the initial wavelength which is going in, the 488 nanometers, is reflected off. And it's only the fluorescent light which is actually shifted away from 488 nanometers that is recorded on the electronic media. That's called autofluorescence. Same thing holds good for near infrared as well, wherein you can use either reflectance or fluorescence. Coming to fundus autofluorescence, it is a good tool to have, good modality to picturize and see and appreciate. But is it of real any practical value in the management of patients? We understand that lipo of our skin is the predominant fluorophore, means the pigment which emits fluorescence in blue light autofluorescence. Fluorophore is a term used to describe a pigment which emits fluorescence when you expose it to light. Melanin is the predominant fluorophore in near infrared autofluorescence. Practically, as I said, in clinical usage, most photographers will do autofluorescence automatically, along with fundus photography and angiography. But in very few conditions, you really need it. And those are in the follow-up of a geographic atrophy. For example, you've got ARMD and you're doing an epidemiological study to see how it is progressing. Fundus autofluorescence is an excellent tool to evaluate them, because we know now that the margin of the geographic atrophy has specific properties on fundus autofluorescence compared to the center, which is totally atrophic. We also can use it to characterize the junctional area in geographic atrophy, as I told you, because certain features of the junctional area bordering the normal retina could indicate the propensity for the geographic atrophy to progress rapidly. In the evaluation of chloroquine toxicity, this has become a standard of care. It means when your patient is put on hydroxychloroquine for rheumatoid arthritis, and you as an ophthalmologist are following up these patients, as a part of your follow-up protocol, you should include fundus autofluorescence. In study of diseases such as retinitis pigmentosa and vitelliform degeneration, they may be of some value. Now let us talk a little more in detail about the most commonly used imaging technique in ophthalmology, that is fundus fluorescein angiography. As the very word indicates, it involves injection of fluorescein, and you study the fluorescence that emits out of the eye following this injection of the dye. So the physical principle is that of luminescence, which is more generic term than fluorescence, wherein light emission that occurs when a substance is stimulated by electromagnetic radiation. But fluorescence is a word you use when you describe the same phenomena occurring in the visible spectrum of the electromagnetic radiation. So what happens in fluorescent angiography? You inject the dye, which is everywhere in the body, including the retina and choroid, and then you expose it to the excitatory energy using a light of specific wavelength, and the fluorescein converts it to a different wavelength, and the emitting light is now is coming out of the eye. So you use two filters. One is the exciting filter, which converts the white light into a light of 465 to 490 nanometers, and what is converted by the fluorescein is emitting in a range of 520 to 530 nanometers. And you don't want this to get mixed up with this. So you cut off the reflected light by using a barrier filter. So that's the principle of fluorescent angiography. So you require now an excitatory filter, a barrier filter, a photographic equipment which could be film or digital media, and a dye to be injected or administered orally. If we inject it intravenously, it comes as a bolus. While if you get administered orally, it slowly accumulates in the eye. So you can only use the late phase pictures will be of any value if you administer orally, like cystoid macular edema. While in most other events, you would require an intravenous administration. So what is the normal behavior of fluorescein based on which you interpret your angiograms? Three things you should remember. That fluorescein molecule does not escape from the retinal circulation normally because of two barriers, the inner retinal blood barrier and outer retinal blood barrier. The inner blood retinal barrier is made of the vascular endothelium, retinal vascular endothelium, which is tight junctions, and the outer blood retinal barrier is made of the retinal pigmentary epithelium, where also they have got tight junctions between the cells. The choriocapillaries, in contrast to the middle layer called the satellus layer and the hallux layer, are the huge cell layer, are freely permeable. That is, hallux layer and satellus layer are not permeable. Are not permeable to fluorescein. Hallux layer is not permeable to fluorescein, while satellus layer to some extent is permeable to fluorescein, and choriocapillaries is freely permeable to fluorescein. So the minute you inject fluorescein, it keeps leaking out of the chorea capillaries and forms a fluorescein pool in the choroidal area. The hemodynamics involves that when you inject it into the antecubital vein, it takes roughly about 12 to 15 seconds. If you inject it on the back of the hand, it takes a little longer. And if somebody has a carotid occlusive disease, it takes even longer. The choroidal filling takes about 0.5 to 1 seconds before the retinal circulation, and hence the need for taking very early pictures. Then follows the arterial phase, early venous phase, etc., which we will come to a little later. So the normal angiogram, the choroidal phase is typically like this, where there's a background choroidal flush. You don't see individual choriocapillaries because very quickly it comes out of the blood vessels. And you see ciliary vessels filling along with the choroidal circulation. Then the arterial phase is where you find the entire artery filling up. You don't find the wave front. The reason being that arterial circulation is very turbulent, and hence you don't see the wave front. That is separation between the dye-filled area of plasma and non-filled plasma you do not see in artery. And then you get the vein is not still filled up, and since the artery leaks out of the small vessels and gets back in through the small vessels, and the earliest dye is coming into the retina in this area, and the dye is least in the periphery, is it not? It's coming much later in the periphery. So you find this so-called laminar flow. Why do you get laminar flow? Is because of the reason I explained, that the dye is coming out into the retina in the posterior pole first and in the periphery later. And hence the blood that is coming from the periphery is filled with dye much later than the dye that is coming from the posterior pole. And hence you get the laminar flow, right? And it's again laminar because it's not a turbulent flow in the veins. Then you get the mid to late phase where the whole vein is filled up. And then of course the later recirculation phase, which is about 8 to 10 minutes later, where you find some amount of background for choroidal fluorescence, and sometimes the disc starts to stain at this stage. Adverse reactions are possible. You get mild yellow staining of skin and urine, which are not of importance. Very often when you inject the bolus, they get a nausea, but a few people may vomit. So you must be prepared to face these consequences when you inject the dye. A few people again complain of paresthesias, but more serious complications would be allergy in the form of urticaria, bronchospasm, angioedema, and rarely anaphylactic shock. These are extremely rare, fortunately. But a few centers routinely give antihistaminics before they administer intravenous fluorescein. And some people do routinely a skin testing of fluorescein before they inject the dye. How far it is useful, nobody knows. The serious complications resulting in death have also been reported, but they are extremely rare. So 4 terms we need to remember when we interpret the angiogram: hyperfluorescence, hypofluorescence, autofluorescence, and pseudofluorescence. By using these 4 terms, you can describe all fluorescein angiograms and then interpret them accordingly. So for interpretation, you require a fundus photography or a knowledge of how the fundus looks like. Otherwise, just looking at the angiogram, you should never make diagnosis. Although you can make in a few cases, that's not what is expected. You like to interpose or extrapolate the data you found from the angiogram on the fundus photograph and then come to conclusions. So what is pseudofluorescence? Pseudo, as you know, is something false. So there's no real fluorescence there. You're made to believe that there is fluorescence. And why? It's because of a mismatch in the excitatory and barrier filters. Hence, you know whether the filters are matched well or not by the first photograph which the photographer takes, wherein without the dye in the circulation, he takes a picture with both filters in place. So normally that picture will be almost black, except for a faint outline of the optic disc. If that is the picture with no features visible, then you know the filters are well matched. Otherwise the filters are not well matched, which means what is going in through the excitatory filter is able to come out through the barrier filter, which should not happen. Autofluorescence, on the contrary, is where the filters are good, but the pigment or the natural structures in the eye are able to change the wavelength by themselves without the help of the dye. And there are structures such as the normal optic disc, drusen, calcium in the eye, or hard X-rays, etc., which are known to have this capacity of autofluorescence. So again, this background information is important for you to be able to interpret your angiograms. Let's come to abnormal angiogram. As I said, two important terms we use to describe an angiogram, hyper and hypo. And what is it? Hyper in relation to and hypo in relation to? Hyper and hypo are in relation to what is normal. So you should know what is normal before you know what is abnormal. Okay? And this hyper and hypofluorescence can affect both retinal, choroidal fluorescence or both. So hypo, as I said, is reduced fluorescence in circulation, or it is hidden from your view. This fluorescence is available there. It's not that it could not reach the place, but it's not visible for you due to something which is blocking the fluorescence. So the blocked fluorescence, as I said, depending upon its choroidal alone or choroidal and retinal, you can know which is the location of the structure which is blocking the fluorescence. Now here is a case of melanoma. You know melanoma is a choroidal tumor in this case, okay? You would expect that the retinal circulation should be intact on top of it. It's only the choroidal circulation which is expected to be blocked. But you find in this case that even the retinal circulation is blocked. That is because the melanoma has actually invaded the retina and is present in front of the retinal blood vessels and has entirely blocked it, this pigment. In contrast, here is a case of subretinal hemorrhage. You see this? And the hemorrhage is actually blocking the choroidal fluorescence in this picture, but it does not block the retinal blood vessels which are freely coursing over the lesion. It tells you where the lesion is. Similar picture of a choroidal nevus which is blocking the choroidal fluorescence and not the retinal fluorescence. Now contrast that blocked fluorescence where you are able to compare the extent of the blocked area or hypofluorescent area with what is blocking on the fundus photograph, and hence you infer this is blocked fluorescence. Now in this case, this area is normally in the small area in the center is what's called a foveal avascular zone, which we all know. If you know how much is the normal foveal avascular zone, you immediately know from this picture that this is abnormal foveal avascular zone. It is enlarged foveal FAZ, and there is a blunting of these vessels which are perifoveal blood vessels. They are not tapering down to capillaries as if something has cut them off at a particular place. Very typically you find this when there is a retinal infarction like aminoglycoside toxicity. You find this whole center of the retina is knocked off. Then you find this kind of a cutting off effect, Alright, now this hypofluorescence is because the retinal circulation has been blocked by lack of circulation. Now the one below is a case of systemic lupus erythematosus with severe vasculitis systemically, including the ophthalmic artery, and has now a ocular ischemic syndrome. You will find here that all vessels are totally sclerosed, and you find hardly any retinal vessels filling up except the major blood vessels and the optic disc area. There is a choroidal flush, the optic disc also is staining, but you don't see any retinal vasculature seen. So that's all called as a filling defect because there is no fluorescein dye in the circulation. Similar picture here, this is a combination of blocked fluorescence and filling defect. You'll find here blockage caused by this blood, blockage caused by this retinal edema or opaque nerve fiber layer. And in addition, you find the entire circulation is knocked off. All the capillaries are closed down because of a branch retinal vein occlusion. This is obviously very severe ischemic BRVO. Most BRVOs are ischemic, as you know. You find that this is the picture. You also find incidentally hyperfluorescence, we will come to a little later. Again, this is a case of hypofluorescence, wherein you find that there are patches of blocked fluorescence due to hemorrhages, as well as an enlarged foveal avascular zone due to a case of branch vein occlusion, or due to diabetic maculopathy. Let's talk about hyperfluorescence. That is, there is more fluorescence than what you expect. It could be because the normal fluorescein is visible little more, because the normally blocking structures are not present, like retinal pigment epithelium, or there is a greater presence of fluorescein, in which case we use three terms called leaking, pooling, and staining. Now here is a picture where you see a combination factors of hyperfluorescence and hypofluorescence. A typical laser photocoagulation mark has a center which is hypofluorescent because the choroidal vasculature, choriocapillaries is also destroyed. But the rim is very often hyperfluorescent because near the rim the choriocapillaries is still intact, but the retinal pigment epithelium is damaged. And hence you see something called as a window defect. That is, you see the normal choroidal fluorescence through the absent retinal pigment epithelium. So a typical photocoagulation mark is central, hypofluorescent, with a rim of hyperfluorescence. And you also see this large frond of new vessels which is leaking this dye. Again, you don't need a fluorescent angiogram to diagnose these new vessels. It's obvious, is it not? But for academic value, this was photographed. But what you see, there are indications for angiography which will come to a little later. But what you see here is hyperfluorescence profusely present in the posterior pole, roughly outlining the new vessels. But I want you to also observe that the edges of this fluorescent patch are more intensely staining than the center. That's because the edges have the most recently formed capillaries compared to the center. So they are more leaky than the center, which have got partly matured. Now this is a case where fluorescent angiography was really useful because you could identify a leakage in the late phase, a patient of pan-uveitis with a subtle macular edema. These days we don't rely on fluorescent angiography, we will rely on the next optical imaging tool which I will discuss later. But this will also give you the same indication of presence of cystoid macular edema. This petalloid fashion indicating that they are located in the outer plexiform layer. This is typical of the cystoid macular edema. Now this is hyperfluorescence present in the deep to the retinal layer. You can make out the blood vessels coursing over the hyperfluorescent patch, which becomes most intense in the late phase. This is a typical case of a choroidal neovascular membrane due to age-related macular degeneration. Again, a subretinal hyperfluorescence due to a disease which you are very familiar with, the so-called central serous retinopathy or central serous chorioretinopathy, the more accepted term these days. It starts as a pinpoint leak and then leaks into the subretinal space like a smokestack. You see, it's filling up the entire area of subretinal space. Now here is the photograph of a patient where you see all the choroidal vasculature, especially the Sattler's layer and the Haller's layer. You don't see too many choriocapillaries, but you see the rest of the two layers. It indicates that there is something which is normally blocking the choriocapillaries, which is missing here, and that is the entire retinal pigment epithelium is gone. So this is a huge window defect. It's almost like ICG angiography. You see all the choriocapillaries, choroidal vessels. The choriocapillaries also are destroyed because of a choroidemia. Okay. So the next dye which we use in angiography is indocyanine green angiography. Indocyanine is a tricarbocyanine dye. It's bound to protein to a 98% extent. That's why it doesn't leave the blood easily. And hence it is present inside even the choriocapillaries. It doesn't come out of the choroidal blood vessels. It absorbs light in the near infrared range, the 790 nanometer range, and emits in 835 nanometer range. It's excreted in the bile, and hence people with hepatic insufficiency, it's better we don't use ICG. It does not leak out of normal retinal and choriocapillaries. ICG is far more safer than fluorescein. So you can use either digital flash camera or scanning laser ophthalmoscopy based cameras for ICG. SLO based cameras gives you much better picture with more definition than digital flash cameras. The reason being that the corneal influence on the fluorescence is eliminated by the ICG, by the scanning laser ophthalmoscopy. So the white light, this is typical example is the Zeiss camera, while this is typical example is the Heidelberg camera. So the digital flash cameras, excitation filter is 640 to 780 nanometers, so still a broad range, and barrier filter is 820 to 900 nanometers. But contrast this with the SLO based one where there is a monochromatic laser light that is focused and a 805 nanometer barrier filter. Hence all the laser light is totally filtered away. It's also confocal, and hence you get extremely crisp, clear image. And up to 12 frames per second are acquired here, and hence you get a dynamic ICG angiography. It fills from the outer largest choroidal vessels, then the medium middle vessels, and then the choriocapillaries. So unless you know the sequence, because they overlap on each other, you cannot understand what is happening in ICG angiogram. And choroidal circulation, as I said, is better delineated with ICG. Specific indications are in characterizing type 1 choroidal neovascular membrane. Type 1 is sub-RPE and type 2 is pre-RPE. Okay? It identifies feeder vessels, especially when using dynamic angiography with Heidelberg machine. in type 1 and type 2 CNVMs. It differentiates between RAP lesions. They are now labeled as type 3 lesions. Retinitis, retinal angiomatosis proliferans, or RAP lesions are now labeled as type 3 lesions. And you can differentiate between the two. You can identify choroidal polyps in a patient with age-related type of macular degeneration with massive hemorrhages. And it tells you that central serous chorioretinopathy is not restricted to a small point of leak, but it's a more diffuse disorder than what is obvious. There are other indications such as choroidal hemangioma, where you see the hemangioma lesion almost instantaneously after you inject the dye. Within 1 minute, bright staining occurs in choroidal hemangioma with a late washout effect. The washout effect is because the dye doesn't go out of the blood vessels and gets washed out. Choroidal melanoma, you can identify tumor vasculature, but you don't really use it for that purpose. But one area where it is very useful is in the varix of the vertex ampulla. You can actually diagnose the varix of vertex ampulla by using ICG angiography beautifully. This is a case of PCV, or so-called polypoidal choroidal vasculopathy, where you can see that in fluorescein, the area of leakages are not as clearly evident, although you do see two spots. But what you see in ICG is clear-cut polyps in the macular area. And following photodynamic therapy, they have disappeared. And in chronic CSR, this is a case with recurrent CSR, where you find that the entire posterior pole has window defects. There's a lot of scarring here with RP hyperplasia, causing blocked fluorescence here and hyperfluorescence in the posterior pole. But you don't find a specific point of leakage that you can target as a treatment. What you find in ICG is an abnormal hyperfluorescence in the entire posterior pole. You can see in the late phase. And when you treat this whole area with PDT, you find that the entire fluorescence has gone, and actually the vision has improved. And in the RAP lesion here, this is a case you see the tiny blood hemorrhage in the retina with this blood vessel coming and ending at this area. And you see some hyperfluorescence here in fluorescein angiography, but you really do not know what is happening because in the late phase, this combines with a cystoid change here. So you don't know which part of it is the neovascular part and which part is just a leaky part. But ICG tells you that the neovascular part is just the small area, and that's what you target if you want to really do a PDT. Of course, in the days of anti-VEGF treatment, it may not be important to know where the actual point of leakage is. Now we'll switch to the OCT, which will be the last part of my talk, or the optical coherence tomography. The principle is similar to ultrasound, except here you use reflected light and not reflected sound energy. The resolution is of the order of less than 10 microns, and no contact is required, and use near-infrared laser of 820 nanometers. If you use longer wavelength, such as 1000 and above nanometers, you get more deeper penetration, but the currently available, at least most commonly available OCTs use the 820 nanometer or in the vicinity of 820 nanometer wavelength. Now, the principle is that the light gets reflected from the boundaries between structures to different degrees depending upon their optical properties. You have each tissue has different optical reflectance property, and depending upon that, the junction may be highly reflective or lowly reflective. And the echo delay is compared with the light which is projected in a reference mirror, which comes back immediately. So the time taken for the light to come back from the reference mirror is compared with the time taken for the light to come back from each of the interfaces to know where the depth lies. So this interferometer, or something called Michelson's interferometer, integrates these points over a 2 millimeter depth. So normal OCTs, unless the enhanced depth is used, only give you a 2 millimeter depth or 2000 micron depth of OCT. Tomogram. The tomogram is reconstructed. Okay? This is the basic principle of OCT. You've got the time domain OCT, where there is a rotating mirror which collects the information from each of the spots where the laser is projected, and a single photo detector. And hence the speed is naturally reduced because there is a rotating mirror. Hence the number of scans per second are only about 5000. While the spectral domain or the Fourier domain OCT has multiple photo detectors, so there is no rotating mirror. And nearly about 100,000 scans per second can be done, and hence it automatically increases the resolution of the image. And you can also construct three-dimensionally the whole picture. The newer version is a swept source OCT, which I'll talk to a little later. This is the swept source OCT, which is a time-coded frequency domain OCT where the scanning is increased even beyond 100,000. And hence you get very high resolution scans as you can see in this picture here. You also have the enhanced depth OCT, which I will again talk to a little later. The limitations of OCT are presence of corneal edema, like any device which depends upon light entry into the eye. Any opacity in the media can affect the resolution of the image. But even in an undilated pupil, if it is about 4 millimeters and beyond, you can get reasonably good image. But if it's less than 3 millimeters, you will have a compromise on the image quality. Lenticular opacity, vitreous opacities, etc. also compromise the image quality, and periphery in general is not visualized properly. Up to equator, even with difficulty you can probably scan, but beyond that becomes difficult. So the normal retinal, it's almost like a histopathology of the retina being seen, the OCT. The posterior hyaloid is lowly reflective and could be found detached, but if it's attached you don't see it as a separate line. The internal limiting membrane is very clearly defined because it's a border between a contrast between a non-reflective vitreous and a reflective retina. Nerve fiber layer is also highly reflective, which is present here, and it's more visible nasally because the nerve fiber layer is thicker nasally rather than temporally. Here it is thicker and here it is thinner. And you have the characteristic depression of the fovea visible with a compact central part of the retina. The internal and external plexiform layers are slightly reflective, and they could be recognized. In general, nuclear layers are hyporeflective and the plexiform layers are hyperreflective. Photoreceptors are very lowly reflective because they are radially oriented. They don't reflect back light much. But there's a very, very important layer, the 70 micron outer highly reflective band, which corresponds to retinal pigment epithelium, which will be the focus of our attention. Blood vessels give rise to cone shadows, and choriocapillaries and Bruch's membrane are seen as a less reflective structure. Now if you see this particular picture, it tells you all the layers. The internal limiting membrane here, the nerve fiber layer is immediately beneath that, which is highly reflective. The ganglion cell layer, which is cellular layer, so it's hyporeflective. The inner plexiform layer, which is nothing but the intermixture of axons and dendrites between the ganglion cell layer and the inner nuclear layer. The inner plexiform layer is slightly hyperreflective, not grossly hyperreflective, but slightly hyperreflective. So the inner nuclear layer contains the nuclei of these bipolar cells, etc., that is located here. And then the outer plexiform layer is again intermixture of the axons and dendrites connecting the nuclei of the bipolar cells with those of the photoreceptors. And the horizontal cells. So the outer plexiform layer is again slightly hyperreflective. The outer nuclear layer is larger. You can see these contain the nuclei of the photoreceptors. These are again hyporeflective. Then you have this band, a 70 micron band, which in the higher resolutions of the time domain or Fourier domain OCTs, you can see actually is made up of 1, 2, 3, 4 layers, not just one layer. Previously we were thinking it's just one retinal pigment epithelium, but now we know it's made up of 4 layers. And what are these 4 layers? The innermost layer, which is slightly hyperreflective, not gross, is external limiting membrane. We won't worry about it too much. But what we might worry about is the next densely hyperreflective membrane, which was previously interpreted as the ISOS junction, that is the inner segment, outer segment junction of the photoreceptors. And disruption of this reflects on the visual acuity of a patient. While now we know that it's not really probably the ISOS junction, but it actually is reflected by the ellipsoid segment of the photoreceptors. Then the ellipsoid part of the inner segment of the photoreceptors. Then you have the another line here, which was previously thought to be the tips of the cones, the outer segment tips. But now we know that it's actually the junction between the cylinder of the retinal pigment epithelium and that of the cone tips. So it's not the cone tip itself, but the junction between the cone tip and the retinal pigment epithelium, which causes this third reflective membrane. And the fourth highly reflective membrane is the retinal pigment epithelium. So now you know the histology of the eye as reflected on the OCT. And then you have the choriocapillaries here, which you can see much more clearly on the enhanced depth OCT. Right? and you see this normal foveal dip, and you see the layers merging into the foveal dip, because in the center we have nothing except the rods and cones and the nerve fiber layers coming to one side away, so that the cones have got the highest visibility for the light. So in summary, the normal reflectivity is highly reflective layers are retinal nerve fiber layer, the previously thought ISOS junction, which is nothing but ellipsoid inner segment of the receptors, the outer segment tips, which was thought to be the third layer, but it's actually the cylinder of contact between the cone outer segment and retinal pigment epithelium. These are the highly reflective layers. The moderately reflective layers are formed by the plexiform layers, that is the nerve fibers where the axons and dendrites meet. That is intermixture. It is not regular structure, so it reflects light better. While the nuclear layers are more regular structure, so they reflect much less. The external limiting membrane also is moderately reflective. But the low reflective layers are the ganglion cell layer and the other cellular layers, inner and outer nuclear layers. So in general, remember that nuclear layers are hyporeflective, nerve fiber layers, the plexiform layers are hyperreflective, the nerve fiber layer itself is very highly reflective. Okay? So the morphological variations are the deformations of the entire retina. It could be concave in myopia, you can see it clearly on the OCT. It can be convex or elevated as a pigment epithelial detachment or a tumor. You can never image the entire tumor, so don't use OCT to image a choroidal melanoma, because as I said, its entire depth is only 2 millimeters. And we know that it's only beyond 3 millimeters you start suspecting a melanoma compared to a nevus. So below 3 millimeters you still call it as a nevus or a neovoma, etc., etc. So you do not use OCT to image a melanoma. You can image it to some extent a hemangioma, but not in many tumors. The foveal depression can disappear. The normal foveal dip can disappear, indicating that the fovea is getting swollen. The retinal surface could be distorted due to a macular pucker. There could be macular pseudo and true holes. OCT has totally revolutionized the way we look at the macula, because clinically, however good your visual acuity is 6/4 and above, you can still have difficulty in identifying finer details in the fovea. And it's OCT which makes it clear to us what exactly it means. It allowed us to stage the macular hole. We all know Donald-Gass macular hole classification, which is based upon slit lamp biomicroscopy and not on OCT. Now we know the so-called stage 2 of gas is actually a full thickness hole. It is not a partial thickness hole. While the original gas classification, the yellow dot is a stage 1, the ring is stage 2, and then only comes the full thickness hole, stage 3, which is partial, and stage 4, small. Stage 4 is a large hole with PVD. That's the original gas classification. But now we know that from stage 2 onwards, it's all full thickness. It's just that the size of stage 2 is less than 400 microns, and in stage 3 and above, it is more than 400, and in 4, it is PVD. So there's varying amount of retinal edema and subretinal fluid. You can have changing reflectivity. In superficial lesions, epiretinal membranes throw up highly reflective shadow. The superficial hemorrhages can produce highly reflective areas, and cotton wool spots do the same. Intraretinally, again, hemorrhages and exudates, the lipoproteins, and fibrosis and disciform scars all produce highly reflective images. And deep lesions such as retinal pigment epithelial hyperplasia, drusen, nevi, and deep scars all produce highly reflective shadows. Hyporeflective, we don't see the reflection which you normally see is an atrophic retinal pigment epithelium. So if you see the shadow of retinal pigment epithelium after a patient has had extensive RPE scarring, you'll find it RPE layer, the fourth part of the last layer, will be hyporeflective. Any fluid in the retina will produce low reflective shadows, intraretinal or subretinal pigment epithelium. So when you have a pigment epithelial detachment where RPE is bumped up, and underneath that you have something, you can actually categorize the content of the PED, whether they are optically clear, is it optically clear space? If so, it is a serous PED. Or it may be hazy with some reflective shadows indicating the cellular debris inside that, indicating of a fibrovascular PED. It could be densely blocked, it means nothing goes through, then you know it is all hemorrhagic PED. So in general, the effect of blocking the light entry is called as a screen effect. You see the screen effect by normal blood vessels which throw a shadow, or you can see in lipid in the retina, you can find it blocking it, or cotton wool spots, hyperplasia of RPE, etc. All these block the light. You can see this is a case of the normal foveal dip, but you see the lipid here, which is blocking the light, and hence you have this shadow effect. You don't see even the RPE properly. So what is the application of OCT? As I told you, it almost replaced fluorescent angiography in the follow-up of most of the retinal disorders that are treated with anti-VEGF drugs or laser photocoagulation. So you follow up the macular edema with OCT now, not with angiography. You may do once angiography, but never repeatedly. It allows us to diagnose clearly and precisely macular holes, CSME, macular pucker, VMT syndromes, foveal schisis, cystoid macular edema, etc. A few pictures. We see this is a case of cystoid macular edema. The normal foveal dip is missing. You find the fluid spaces within the retina. This is a case of full thickness macular hole. You see the clear gap in the retinal structure. You see the bare retinal pigment epithelium visible here, and you see this this pyramidal shape, which is characteristic of a full thickness macular hole, and there is cystoid spaces in the retina around it. In contrast, this is a lamellar macular hole. I would bet anything that with circular biomicroscopy, you'll have great difficulty in differentiating this from a full thickness hole. While OCT clearly shows you that there are layers present at the base of the hole, telling you it's a lamellar hole and not a full thickness hole. You see this clear picture of a vitreoschisis. You see a thick membrane in front of the retina, and it's split actually here with the second membrane here. So this is the original vitreous, which became like a periretinal membrane, and this is a detached vitreous membrane. You find another schisis here. So the concept that vitreous can actually split and separate, and what you see as a posterior highlight is not really the true posterior highlight, is something which is very clearly made out on OCT. And you see here the vitreomacular tractional syndrome, with traction clearly made out at the foveal level, causing the macula to be swollen up with collection of fluid. And you see here, if you see clinically, you will see a membrane in front of the retina. You do not know whether this is causing foveal traction or not. If this is a patient who has had a diabetic macular edema, you are not clear whether you should operate on this membrane or not. You know on OCT now that there is no value of surgery because the foveal dip is absolutely fine. So there is no traction on the fovea at all. And the vision, if it is poor, it is because of other reasons, maybe macular ischemia, not because of this membrane. So it allows you also to evaluate the efficacy of treatment, the anti-VEGF drugs, laser photocoagulation, etc. Whether it's photodynamic therapy or vitreoretinal surgery for macular holes, it tells you whether you are successful or not. As you can see here, in a case of diabetic macular edema with swollen macula, you see also the vitreous, which is partly detached from the retina perifoveally, but it is attached at the fovea. This is not causing any vitreomacular traction, it's just lying limp. But you see, following anti-VEGF drugs, it has become totally flat. Likewise, an periretinal membrane in front of the fovea with fluid space in the fovea. Following the removal of the membrane, the foveal dip has got restored. There is still a small fluid space. Perhaps after a few more months, this will also disappear. And you find similarly macular holes preoperatively, right eye and left eye of the same patient, and following surgery, the hole is closed. So you can see very clearly that the hole is closed. You can actually follow them up over a period of time to see what is happening to the hole. Very often you find that even on the first post-op day, the hole becomes small, and even within 1 week, the hole can be closed, because you can image with those even through air in the eye. And it allows you to prognosticate macular hole because it tells you what are the, you can see that this side of the macular hole is actually made of one component which is swollen retina and another component which is detached retina, separated retina and detached retina. So the combination, this is called the hole forming factor, devised by a fellow called Pugliafito. Carmen Pugliafito has devised this particular formula, which is C plus D by A. C is a side, these sides. You add them up and divide it by A. As you know, the denominator is A, which is nothing but the amount of bare RPE. It tells you that the larger the base of this cone, okay, then it's going to reduce the overall number, because if the denominator is less, the outcome of CD plus by A will be less, not more. So if it is less, the prognosis is worse. If it is more, the prognosis is better. Means if the sides are longer, but the base is shorter, then the prognosis is better. Okay? There are other indices also based upon the OCT, which I will not discuss. It also tells us the types of closure of macular hole. It's not that all macular holes close with the normal restoration of the retinal anatomy. This is normal restoration of retinal anatomy, which is what you want and desire. But that doesn't always happen. Very often what you find is that the edges may be brought together, but full restoration of contour may not be there. But in some cases you can actually see the gap here persisting, but there is no retinal edema on the sides. That is still called as a closure, but it's called type 2 closure. As I said, the biggest value was in the following up of patients with treatment with anti-VEGF drugs, wherein you keep the OCT as a tool which tells you whether I should inject more or I should follow up. You can see the amount of fluid in the retina, foveal detachment, etc. can be detected on the OCT and use that as a tool for comparison. Lastly, innovations in the OCT were on the ultra high resolution OCT, which is what you see here. It gives you better delineation. In this picture, as you can see, this ultra high resolution. You can make out these layers so clearly and crisply. This is not any fluid, but this is the normal presence in ultra high resolution OCTs. You'll find the central layers dip up a little bit. And the en face OCT is where it's like a flat surface view of the retina, as if somebody has taken a picture of the OCT from the side, from the surface, on the surface of retina. This is how it looks. So as you go deeper and deeper, in the entire scanned area, you will get the OCT picture. This is en face OCT. Enhanced depth OCT enables you a good demarcation of the choroidal thickness. And we know now that the choroidal thickness could be a very important factor in the causation of many diseases, including AMD. And hence measuring choroidal thickness could be an important parameter in the future. Thank you very much for your patient hearing.